So, thanks everyone for joining us. I'm very excited that we've got Dr. Jennifer Stagg with us today. As is our desire, first of all, let's get everyone to put it on mute.
I thought I would, but
There we go. We've got everyone on mute, I hope. Good. So, very excited to have Dr. Jennifer Stagg with us. She's a practicing naturopathic physician, and as you guys know, we all like to have practicing physicians do these talks on the basis they're in the trenches as you are. So again, we want to make sure that that's an important element for us in terms of just admit a few more people in here. That's great. Admit all. But she works. She was the founder and the current medical director of Whole Health Wellness Center in Connecticut. She is also a renowned author of The Bitter Prescription and Unzip Your Genes, and is routinely featured as an expert guest in the media. And again, what we really like is she's a practicing physician and focusing on a number of areas which I'm sure you're all familiar with in terms of thinking about the fit test. So digestive health, and she's got some fantastic case studies that we'll be going through today. Mental health, weight loss, resistance and nutrition, healthy aging, nutrigenomics, and metabolic and endocrine disorders. So again, it kind of really runs the gamut of the number of things that we use the fit test for, and we hear all of our providers doing the same thing. So without further ado, I'm going to be in charge of admitting more people, and if you've got any questions, I'll be making sure I'm monitoring the chat as well, and there'll be time for questions at the end as well. So without further ado, over to you, Dr. Jennifer, to go through the fit test and how you're using it in the practice with some of those great case studies that you talked about before.
okay, great. Thanks so much for having me, James. Hopefully I'm having a little bit of a technical issue on my screen where I can't get rid of a little box here. I don't know what's happening here, but obviously I'm sure you can all see my slides, right? Like, and not seeing a big box in the middle of it.
No.
I hope not. You're just seeing the slides. Good.
You're just seeing slides, so that's good.
Okay, perfect. All right. So again, thanks for having me. And today I'm going to give a brief overview of the fit test, but really talk about the way I use it in clinical practice and the utility in case management. And today I'm really going to focus on GI health because it's a really, if you've not used the test much, it's an easy entry into using it, and you'll find that you'll get really good clinical outcomes with your patients. But of course, you can use it in a broad range of categories. So I'm also going to give you a little bit of overview of how to manage functional dyspepsia as well as we go through those cases. Some of the focus is on GI health and functional bloating, and I will overview that at the end. So I have a comprehensive review there at the end. So first, let's just start quickly about defining what food sensitivity is versus allergy versus intolerance. So food allergy is this IgE-mediated type 1 hypersensitivity. And that is really key to understand. And when you're talking to maybe an allergist or someone, a conventional provider, it's important to really distinguish between food allergy versus food sensitivity. And food sensitivity, which is what we're testing for here with the FIT test, is a hypersensitivity reaction that's in the IgA or IgG category. And then food intolerance, on the other hand, is non-immunologic. And that would be more sort of like lactose intolerance would be a good example of that. So when do providers really use this FIT test? Commonly, it's used with patients who are having GI issues that I pointed out, first of all. Things like fatigue, brain fog, autoimmune conditions, really important to think about FIT testing, and of course, GI health there, migraines, a whole host of different reasons why people really use the FIT test in clinical practice. And this is sort of from a summary of providers who use the FIT test in clinical practice pretty regularly. let's see. So the FIT test is really a great approach to use in a integrative medical practice because of the ultimate sort of underlying disease mechanism of
Hi, Sandra.
inflammation.
Can I
So
bring my book with me?
okay, we just need to keep everybody on mute. So
Right. As they come in, we're kind of trying to mute them.
try to mute them. Yeah, I know.
Apologies.
We'll have a little bit of that. So inflammation is considered to be the root of a lot of conditions, or certainly at play in a lot of chronic conditions and some certainly acute conditions that we're seeing in clinical practice. So important to think about FIT testing here as well. So from an immune complex standpoint, and this really plays into what distinguishes the FIT test from other food sensitivity tests in the marketplace, is this combination of two different mechanisms that are being tested. And so most food sensitivity testing that I was always familiar with and had used in clinical practice with varying degrees of effectiveness in terms of clinical outcomes was testing that looked at IgG, 1 or IgG, sometimes, IgG4. And in this test, what we're seeing, and this is sort of a molecular mechanism overview that shows how the foods and additives, which is really important key here too. With this FIT test, we can actually test for additives, but dietary peptides that are coming into the digestive tract can pass through those tight junctions and end up getting to the point where the antigen presenting cells are introducing those peptides and antigens to a T cell, which then communicates with the B cell, and we get these antibodies being produced against IgG and IgA, or produce the type are IgG, IgA against these dietary peptides. However, what's key here is with the development complement activation, and that's where we get this inflammation. So a lot of times when I'm talking to patients about this type of testing, we're looking at foods that are actually causing inflammation in the gut. So food sensitivity that's resulting in inflammation. And here you can see the dual pathway measurement. So acquired immunity, IgG1 through 4, and then the innate immunity, the complement C3D pathway. So both of those are being tested, and that's what's detailed here in this slide is the difference between just conventional conjugate generates the IgG response to a food antigen versus the FIT test patented to include both IgG 1 to 4 and the C3D, that complement, which gives a lot more validity to this test. And again, in my clinical experience, I've seen this equate to much better outcomes when patients eliminate these foods, and it tends to be less foods that will show up when you actually test it this way. You will see a lot less of those foods on the profile. So when we look at a food profile, here is what your patient is presented with in terms of their testing options. And the way I go about this in my practice is that I pretty much don't recommend the low food test, the 22 tests. In that case, you're not getting a lot of foods that are being tested. I know some people really just want to test the most common allergens, which is fine, but I really want to look at the intestinal permeability markers and also get a broader view of other things that you might not catch on the small panel. So when you order the 132 or 176 version of the FIT test, you also get a gut barrier panel, which I'll talk about here, included in that test. So, which test to run, 132 versus 176? Obviously, 176 is a little bit better. You've got more foods being tested. However, you're going to catch a lot on 132 as well. So I'm okay with either one, and I really leave that up to the patient. because obviously there's a cost difference here between these two panels. So I am comfortable letting my patient choose between 132 and 176 foods. They probably more so, like once they start looking at the foods on this list, a lot of them will choose 176, but even some of them are sort of might have something that they are suspecting they might be sensitive to that's showing up in the list, you know, in that red category, and then they'll go ahead and choose the 176. But either way, I've had good outcomes using, you know, the 132 is certainly like enough. And then you could go that an extra level and go to 176 for sure if the patient is willing to pay for that little jump up. So this is what that report looks like, part of the report. And so you can see here where all the foods are laid out in categories. You can see those red bars representing a much higher immune response, 4+ versus the lower bars here showing 3, 2, and 1+. Also on those panels, as I mentioned before, is a food additive profile. So with this particular fit testing, I know a lot of companies, other competing companies don't necessarily have this food additive profile, which is really key, I think, also in this test and selecting this one for your patients to be able to look at those food additives. Of course, we can all tell our patients, like, you should avoid those, because even if you're not experiencing any immune sensitivity to it, it could be creating other problems on its own, as we know. But certainly if you had a patient who had some significant immune inflammation showing up on those food additives, it would be another compliance tool to get patients to really get rid of those food additives and dyes in their diet. All right. Okay. Whoops. Let's see. I went ahead too far. Okay, next slide. Here we go. So the fit test meal plan is another great aspect of the program guidelines for patients that are provided. So it does lay out what are some good options for them versus just don't eat these foods. So that's really nice to have there, because if you do have a number of different food sensitivities, and again, it usually isn't over the top on these particular profiles because of the testing methodology. You usually can really work around those food sensitivities, but this really gives your patients a nice little guideline for what meals could look like, and then they sort of can go from there. And then let's see. Oops, sorry. Okay, and then another really exciting aspect of this fit test is that KBMO has teamed up with a number of different companies, including Nutridyne, Biotics, and Fullscript, to provide some supplement protocols. And so today, all the supplements that I'm going to talk about are actually Biotics protocols. So those are also available through KBMO in this partnership, which is pretty neat to have access to that as well. So there's also a phone app that's provided for patients that makes it easy for them on the go to really just pull that up quickly and look at what their food sensitivities are if they're out and about and they've forgotten. You know, obviously if they just show up having like 2 things, it's pretty easy to remember that. But if your patient has 8 different foods, they might forget a couple of those. So this phone app that details the actual food sensitivities is pretty neat aspect of the fit test, which is included in the entire cost of the test. So then I did want to talk quickly about the leaky gut barrier panel. That's also part of the test kit and results. And of course, you know, there's this controversy or discussion about like what comes first. Is a food sensitivity, leaky gut? This way we can really test, is there an issue going on that is impacting that gut barrier? So it's a really great aspect of this test. And in this case, again, using this dual technology, using the IgG and complement C3D, and also here IgA 1 and 2. And so what is being tested here is Candida, which is kind of neat too, to actually have that on here. Obviously, you can follow up and do some stool testing. I really like the biome test. I think is really sensitive for Candida if you're going to do some stool testing to look at if there's some significant overgrowth, but this would show is there immune response to Candida at the gut barrier that could be impacting permeability. And then, of course, zonulin and occludin proteins, which would indicate compromised gut integrity there. And then, of course, LPS, which we know can really or does play a really significant role in permeability and onset of disease states. So if anything is positive on here, you're going to want to start to think about protocols to address that gut barrier and really look at why the gut barrier is disturbed in the first place, cutting out some of those foods that someone is sensitive to really will certainly play a key role in there, but then also you can use supplement protocols to help address the level of inflammation and correct the permeability. All right, so then when we look at that on the patient report, you can see how that is presented. You'll see that gut barrier panel there. And I like the two cases I'm going to show you. The gut barrier panel was negative on both of those cases, and one of them had quite a few food sensitivities, but no gut barrier disruption being detected there. So you're not going to, it is sensitive enough to pick up gut barrier issues, but it's not, I wouldn't call it like false positive that you could see with some other testing. So let's talk about my first case here, which I reviewed in detail. Again, I have this little box in the middle of my screen I just cannot seem to get rid of. So bear with me. I should be able to get to all the details here, but if I'm off on anything, it's because there's a box blocking my view of my slides. But anyway, so case one is a 51-year-old female who came in with functional diarrhea. So her chief complaint is she's having some loose stools, some urgency in the morning. She is an HR executive. She's basically, taking some vitamin supplements at this point, vitamin D, B12, multivitamin, taking an over-the-counter probiotic. This patient has Hashimoto's, and she is hypothyroid. Along with that, she's on Synthroid, 175 micrograms, along with T3. So she takes 10 milligrams in the morning and 5 milligrams in the afternoon. And then she also is on a prescription for Lexapro for ongoing anxiety that's pretty stable on Lexapro. So she is a married mother of 2. I hope that's what that says. Her diet is actually gluten-free. So she has found that she is gluten sensitive, and of course, having Hashimoto's, follows a gluten-free diet. She is an omnivore. She drinks some alcohol. Coffee is daily, couple of cups a day. Some significant medical history on her is that she was diagnosed with neurological Lyme and had been on, in the year to 2 prior to developing these symptoms, multiple antibiotics, also on hydroxychloroquine. The development of the GI symptoms that she's complaining of now at this point with this urgency and diarrhea in the morning is many months out from the end of her antibiotic and hydroxychloroquine treatment, just to be clear. She does also have, along with the Hashimoto's, she also has non-specific autoimmune disease. She has a positive ANA. She also has a long history with Raynaud's. She's also reporting some perimenopausal symptoms, heavy bleeding, a little bit of irregularity with her cycle, but more so the heavy bleeding has become more of an issue. Costochondritis, she has flare-ups on and off with that. And so she also gets regular chiropractic care, some acupuncture. She's taken some natural anti-inflammatories for that. She really tries to avoid taking over-the-counter like NSAID type products. She also has ADHD, anxiety, as I mentioned. And then she did have an abdominoplasty in 2021. So this was 2 years. So this patient presented last spring. So this was 2 years prior. She had undergone some plastic surgery that had, no complications. She was happy with the outcome. So her main complaint is that she's having diarrhea, as I mentioned. Often it's urgent. This seems to be about 3 times a week, and then so it's not every day. Other days she's having form stools. She's talked to her primary care provider about it. They're not too concerned. She's up to date on her labs and colonoscopy, and she wants treatment like right away for this, basically. So she wants to start on something. She is open to potentially doing some tests, but she just wants to get rid of it because it's disruptive, obviously, to her morning, working full-time as an HR executive. So I pretty much just went across the board in terms of treatment, thinking about her history with having been treated with antibiotics for so long, considering the potential of bacterial overgrowth and dysbiosis, undergrowth of some beneficial flora. So supplementing with a really good probiotic, Biodoc 3 GI I used here, which is a really strain-specific probiotic by Biotics. That was 1 capsule before bed. And then I did essentially multi and herbal antibiotic formulas by Biotics. So one is FC-cidal, the other one is dysbiocide. And this would cover essentially bacterial overgrowth and fungal overgrowth. So if we're dealing with either one of those products would cover both of those. So 2 capsules twice daily, ideally between meals. It's interesting, this protocol, FC-cidal and dysbiocide, has been studied clinically and compared to rifaximin for treatment of, or Xifaxan, rifaximin is the generic, for treatment of SIBO. And it performed just as well as the prescription antibiotic. And now there's a really great kit that's available, the SBO kit, that is used to treat SIBO, and also includes ADP, which is a enteric slow release oregano oil. And this is provided at a higher dose, like a 1-month dosing kit. So I've been using that a lot. If that had been available at this point, I might have even thought about using that kit here just to cover all my bases. On top of that, GI Resolve, which is a gut lining support. I probably should have written in there, a scoop mixed in water, taken in the evening. So also considering here that there may be some inflammation, of course, present in the intestinal tract, all those like antibiotics, hydroxychloroquine, causing a lot of immune disruption in the gut. And then on top of that, gave her enzymes. So pretty much like covering everything that we could cover to get her feeling better quickly, because she, wants fast track to get better. And so Bio 6 Plus, great concentrated pancreatic enzymes. And then it's important to take those with each meal. So obviously educating your patient that the enzymes need to be taken with the food to help them digest food. Enzymes taken on an empty stomach, on the other hand, when you're using proteolytic enzymes, if they're taken on an empty stomach, then you would want to that approach would be more of an anti-inflammatory or even biofilm. So sometimes that's another thing I'll do here, is have patients take some enzymes also on an empty stomach. There, I would probably use something more like Intenzyme Forte, which is a proteolytic enzyme, to work on biofilm. And the key is, as I mentioned, taking that on an empty stomach. So that's 30 minutes before a meal or 90 minutes after. So a lot of times when I'm thinking about biofilm, I'll have patients do that sort of first thing in the morning and at night. Here, we didn't do that. We just stuck with the probiotic, gut support, FC-cidal, dysbiocide, and enzymes with meal for digestive support. So once she came back for her, I guess that says 1 month follow-up, she reported occasional loose stools, bowel movements 2 times a day. So there was some like significant improvement here. Only 2 bouts of urgency, so that had been reduced prior to treatment. She was complaining of some bloating here, and then also noticing cheese potentially causing a problem, feeling some like tiredness. And then also she is really concerned about perimenopausal symptoms. Periods are getting a lot heavier, continuing to have a problem with that. So she's also looking for support in dealing with that at this point here. So the next thing I thought about was to add on a detox program. So doing a 30-day detox, providing nutritional support, and then coffee elimination reduction. Also, I gave her a schedule prior to starting the detox, which I'll do for some patients. She was drinking 2 to 3 cups of coffee a day. So I wanted her to sort of wean off so she wouldn't have that sort of 2-3 day into a detox program, going off caffeine, just having these caffeine withdrawal symptoms, and she would better tolerate easing into the detox program. I also recommended some gallbladder support too, because of potentially certainly the cheese could be a food sensitivity. It seemed like in general, she didn't eat a lot of fat, and it was more sort of like fatty cheeses. Sometimes that's a sign of issues with bile salts. So the beta plus is a nice trial to see if that provides any additional help there. So really, this patient was kind of like, okay, give me anything. Like, I just want to be better. And she was already a lot better. So we're adding on a couple of things here. But at this point, I was like talking about food sensitivity testing, and she was kind of like, I don't really think that that's the problem, except for, this cheese issue here, but she was still not necessarily convinced that she actually had to cut out cheese. But on the detox program, she was going to cut it out anyway. And then I would have her she could reintroduce some of those foods so we could look at it from that standpoint. Which is a challenge. So obviously, like, elimination and challenge is another way to look at food sensitivity or even food allergy. However, when you're adding back those foods to challenge after you've cut out foods, you're really only, you're limited in what you're adding back in, and you're typically just having them challenge what are the most common food sensitivities. So for someone who maybe is sensitive to, apples, for example, like, you would never know that from an elimination and challenge, right? Like, typically we're not saying, okay, add back an apple and try that and see if you're allergic to that, or sensitive to that. So after this detox program, she came back about a month later again. She had completed 26 days of the detox. Her GI symptoms were really good during the course of the program. And then since she has went off of it, she's been like eating pretty bland, but she's having some urgency. She's back on drinking coffee again regularly because she loves coffee. So at this point, I was like, okay, time to let's look at food sensitivities and see what's going on there. And then also I was recommending, possibly, so it could be something that you're eating, obviously, that you cut out during this, detox program. And she didn't do any defined challenges when she came off the detox. But the other aspect I was thinking about from the standpoint of her heavy cycles, and perhaps she was dealing with some ongoing issue with that she needed liver support. So oftentimes I'll have patients continue to just do a shake, like a 1 serving a day with a detox shake, to provide that ongoing support. So while we waited for the results to come back, she really, had only what I had said I was to just add that detox shake back in. So she was continuing to have diarrhea occasionally. She was reporting loose stools often. She was drinking coffee in the morning, and it seemed like, she drank her coffee, had to go to the bathroom, which is no surprise, right? Because coffee affects the bowel. And so interestingly, this patient came back, she did the 132 on her test profile, and the only finding was coffee and cinnamon. On the gut barrier panel was normal, and this woman drank cinnamon lattes, which is kind of unusual, right? Like, I don't know a lot of people that have cinnamon lattes, but this was her go-to coffee. That's what she drank, a couple every morning. So we were pretty, much on top of that. We're going to have to eliminate the coffee and cinnamon from the diet for at least 2 months. And then because she just reported she really identified with being a coffee drinker, she had signs around her home about coffee in her kitchen. Her family always, made comments about her and her coffee relationship. So it was tough for her. But I wanted her to go off coffee, but she could stay on caffeine. So I told her to replace her coffee with caffeinated teas. If she wanted more of a coffee flavored beverage, then I told her to try Ticino, which is a nice brand that's a caffeinated sort of coffee substitute. And be careful with that one, because there is a brand I realized that has cinnamon in it. So with her sensitivity, I didn't want her to get the one that has some cinnamon. Anyway, so here's her report where she has just 4+ reaction to coffee and cinnamon, and nothing showing up there as 2+ or 3+ on her report, which I found really interesting, and was, of course, anticipating her follow-up to see how she did with it. And then on her follow-up, when she came back, she was off coffee completely for 3 weeks, and her bowel symptoms were completely fine. So she was feeling like this had made the difference for her, and it was worth being off coffee. And she was drinking caffeinated tea, although that has less caffeine than coffee. That could still have some bowel stimulant effect. So it's not like that stimulus that's necessarily the issue. And she was no longer on a lot of digestive support other than probiotics. So she had stopped the detox shake. She had stopped long ago. We only did a short course of not so short, a month-long course of the herbal antibiotics, ceftriaxone and dysbiocide. And so she was just maintaining on the probiotics. She was not on enzymes anymore, and she was not on gallbladder support. And then since then, I've seen her a couple more times, 3 and 8 month follow-ups, and both visits she was reporting that she was asymptomatic since she stopped drinking coffee and having any cinnamon. And she also just had a couple of episodes. Only what she found out afterwards were some hidden ingredients, primarily cinnamon, where she had some food that had cinnamon in it. And then she was taking her probiotic a few times a week, and on her foundational vitamin supplements for other issues she was dealing with. So pretty neat case, I think, here, and I think would be sort of quite challenging to really identify without doing a food sensitivity fit test here in this patient. The other case I want to share with you, and then we'll have some time for questions, and this one isn't as long, I condensed it a little bit more, is a 40-year-old female patient, and she was presenting with functional dyspepsia. So just this, bloating pattern, and had seen a GI doctor and had ruled out some, significant medical issues. She was unemployed intentionally. She was a stay-at-home mom, homeschooling her kids. Her supplements, she was on a number of different supplements and was very health-minded and wanted to, thought she was digging, trying to figure out what to do about gut health, vitamin D, vitamin C, quercetin, taking fish oil, magnesium. Her medications were Advair, Allegra. She'd had asthma from a young age, and had been hospitalized, or certainly in the emergency department, numerous times for pretty severe asthma, and seasonal allergies, also part of the picture here. She is currently on famotidine, a 40 milligram dose that have been prescribed by the GI doctor she had seen. She's married and currently she's on a ketogenic diet. She does have a history of binge eating disorder, and then also history of obesity, anxiety, and some irregular menstrual cycles too. So this was, her first presentation to see me. She was complaining of irregular cycle length, not the period length, but her cycle length was longer. She was complaining of bloating, sort of throughout the day, on and off, like midday and later in the day as well. She had some recent labs that showed some low estrogen. Her gynecologist had told her she was perimenopausal. She'd also seen GI, as I mentioned, and they were sort of pretty much unconcerned with her dyspepsia. They had trialed her on a PPI, and she really didn't feel well on that. She did also have a history of GERD too, and she ended up back on famotidine, which she would have originally recommended to take by her primary care doctor. So when she came to me, I ordered labs for celiac disease, which actually hadn't been done at that point, surprisingly. And then, or in some cases, not so surprisingly, also a SIBO test, obviously, that probably makes a lot of sense for most of you to about SIBO testing here. Whenever there's an abdominal distension bloating picture, you definitely want to be thinking about SIBO. And then, of course, there's another condition, SIFO. So even if your SIBO test comes back negative, a patient can present with all the same symptoms, and it could be SIFO, which is a fungal overgrowth, and there's no breath testing for that. You can do microbiome testing, like I had mentioned earlier here in the presentation. And then I also had her do a home baking soda test, which is a little sort of like clinical trial you can do to see how long it takes a patient to burp after they drink a small amount of baking soda in the morning on an empty stomach. And based on that timing, if they're burping really quickly, then they have plenty of acid. So it's basically, an acid-base reaction producing carbon dioxide. If it's a delayed burp time or they don't burp at all, then it could indicate low stomach acid. In this case, she did say report on her follow-up, a delayed time on the baking soda test. So we started her on a little bit of apple cider vinegar. This was in between, there was some communication in between visits here, and that seemed to help a bit. And she had been off famotidine, and actually felt like that was making a bit of a difference. Her SIBO test was negative. So again, possibly she could have SIFO. We started her on Bio 6 Plus, which is, I hope that's what that says. I'm pretty sure it is because I have that block in my screen. Enzyme course. So this was over the course of a number of different visits. Again, sort of trialing different things that could be going on with her presentation of functional dyspepsia. We did a course of dysbiocide and FC-cidal, with the thinking that this could potentially be a SIFO case. And then we did a KBMO test on her. And so over the course of the, months of visits, again, this patient was also kind of on the fence. And now, I've gotten a lot more upfront with patients. Let's just get this food sensitivity testing out of the way because of some of these cases, which this is why I selected some of these for you, that you can get some progress. And a lot of times it's a bunch of things together, right? But if you could just do this testing kind of right out the gate, you could really get results, I feel like, a lot quicker. So KBMO test was ordered, and she had multiple food sensitivities, which I'll show you here on the next page. And then she started following her food sensitivity plan, avoiding all the foods that she was testing positive for. And even 6 months out, if she eats any of those foods, that's when she gets bloating. So again, like, really interesting case. Here's her food sensitivity test. Egg yolks, egg whites. Eggs were really tricky for her to really cut out of her diet completely. So she knows now, like if she has a little bit of egg and she's no longer on a ketogenic diet, she has a little bit of egg in a baked good, something where it's just a small amount. She reports that she feels okay. But if she eats like actual eggs for breakfast, she'll definitely have bloating in the morning. And then some of her other food sensitivities like turkey, she used to eat a lot of turkey, and so she's had to replace that with chicken, which she doesn't love. Some people, I guess, is the reverse. And then corn, she had been, munching on corn chips quite a bit, and she liked corn on the cob. And so she had a few sort of mishaps where she kind of forgot that corn chips were corn, which she laughed about, and ended up with a reaction. And she's like, why am I having a problem? And then realized, oh yeah, tortilla chips have corn in them. So that was a really interesting case as well. And so she continued to stay on some of those digestive supports as well. Like she does take, digestive enzymes still. She does continue to follow that diet, and she's pretty good. Like compared to when she had first come to me, she says it's like night and day. So she's had a lot of progress. So I just want to sort of just leave you with this slide here about functional dyspepsia from a holistic management standpoint. So obviously, if someone comes in with bloating and distension as their main concern, we can't really call that functional dyspepsia until we make sure it's nothing serious, obviously. So running some potentially abdominal pelvic imaging, making sure for many of these cases, we're ruling out something like you wouldn't want to miss ovarian cancer here or some sort of abdominal mass. So a lot of times in many of these patients, I've done ordered an abdominal ultrasound. And this last patient that we just talked about, she had I ordered an abdominal and pelvic transvag ultrasound on her. She also, we tested her for celiac disease, did full lab workup, nothing was really found on labs. Some of these cases, scoping would be indicated. And then of course, SIBO breath testing, you want to make sure you're ruling that out. But then KBMO fit test is key here for looking at, is this a food sensitivity issue where people are getting functional dyspepsia from food sensitivity, which is very common that I'm seeing that pattern more and more. Microbiome testing, a comprehensive digestive stool analysis to really look at inflammation in the gut in more detail, to really look at the status of the microbiome, look for things like parasites, and also look at digestive capacity, looking for how well they're doing with breaking down fats and proteins, which you can detect all of that in the stool. Also, even in terms of conventional labs, but also would be on a stool analysis, that would be more of a functional stool analysis, as a calprotectin. And calprotectin is an inflammation marker that we see associated with inflammatory bowel disease. So you don't want to forget about that one, I would say. That's another clinical pearl that some people might have this perception that inflammatory bowel disease should present with, diarrhea, potentially bloody stools, mucus in the stools. I have quite a number of patients that have inflammatory bowel disease, and their primary symptom is just like bloating and abdominal discomfort, like really just, and some of them are more sort of constipation profile, and they have Crohn's disease or ulcerative colitis. So certainly, scoping indicated there, but calprotectin is a nice way to screen for that and look in a way to sort of monitor disease severity. So, and that can be just run through your conventional lab, like a Quest or LabCorp. So other things that we think about would be making sure you're not missing anything in terms of the basis for GI function. And the first thing I would say is checking for hypochlorhydria, which I mentioned in that last case, doing a baking soda test to start. If a patient actually has heartburn type symptoms, or certainly had a history of gastritis or peptic ulcers, then I really don't, for like rarely, I really would not recommend using supplementation with betaine HCl, and you could use some alternatives like apple cider vinegar, as I mentioned with this particular case that we just reviewed, the second one. Bitters, lemon, those can all help to stimulate the gastric juices, HCl, pepsin production without the risk that would come with betaine HCl. You also want to think some patients who certainly may not have heartburn or anything and have classic signs of hypochlorhydria, low stomach acid, who are on taking regular NSAID use for pain or migraine, whatever it is. Those patients are at an increased risk of bleeding if you start supplementing them with betaine HCl. So be really careful there. Obviously, you want to think about digestive enzymes, which we talked about with these cases, using a pretty good, like comprehensive, strong pancreatic enzyme.
Sorry, I wasn't sure if I lost you
Oh.
because I've been on.
We had a breakthrough again. Gallbladder support is definitely something to consider here. Another big issue that I'm encountering in my practice, and I'm sure a lot of you are, is issues with the enteric nervous system. So hypomotility primarily here, or like a spasmodic bowel seems to be more the issue. And like a little note or pearl when it comes to SIBO management, so small intestinal bacterial overgrowth, when you're treating that, certainly treating with an herbal protocol, really making sure you're screening for low stomach acid and issues with motility. Those are being detailed in the literature as probably the two primary reasons why so many people have SIBO. So those are things you really want to make sure you're looking at and getting good control of. So prokinetic agents like 5-HTP, certain probiotics are prokinetics, melatonin is a prokinetic. That is dose dependent. If you go too high, it can have the reverse effect. Spasmolytics like Colon Plus is a nice product for spasmy, sort of IBS classic type of bowel. And then microbiome balance. So of course you could do some of the testing that I talked about and get a better understanding of what's happening in the microbiome. But to support the microbiome, of course, probiotics, but don't forget about prebiotics. BioFiber Complete is a really nice powder that has a lot of prebiotics in there for patients who are having a dysbiotic bowel. And then assessing for ileocecal valve dysfunction. If you're not really skilled at that, a lot of, you could hopefully find a provider in your area that has training in visceral manip or an integrative PT, integrative manual therapy practitioner. Some chiropractors are really good at this to really assess for ileocecal valve dysfunction. And then not missing emotional stress and adrenal support, that whole HPA axis, which can influence the microbiome. It can influence the nervous system in the bowel. It influences how well you produce acid in your stomach, whole host of issues there. So you want to really think holistically when it comes to managing these patients with functional dyspepsia. So I hope you learned something today, or something, came together in terms of patients for clinical management. And thanks so much for listening and tuning in, spending an hour here together. Let me know if you have any questions. I know James has some information we want to talk about as well. Do we want to talk about that now or do questions?
Let's do some questions. I'll just kind of quickly give you a breather, given that you've been talking for a little while there.
Okay.
But we've got some great questions about elimination in terms of the time periods to do that, and then I guess at the other end of the spectrum, what's a good reintroduction plan that you've got? So again, I can give you some ideas of what we hear from other providers, but Jen, over to yourself to kind of say, what's the elimination period? Talking about foods
Yeah.
1+, 2+, 3+, and then the reintroduction as well.
Yeah. So elimination period, meaning like eliminating after you've found like the food sensitivities.
Correct. Yeah.
Yeah, so I would say, like, I recommend really eliminating all of them. So I really recommend taking all of them out because, as you can see, even from that patient, the second one, she's still really sensitive to eggs, like 6 months out. She's still having a problem. And that was on her 1+. I think one of them was a 2+. However, my standard go-to recommendation is like, let's cut these out for 4 months and then you could introduce them. And then when you reintroduce them, you want to do one at a time and enough of that food. So as I mentioned with this patient with the egg sensitivity, like having a little bit of egg mixed into a baked good might not be enough. So like the classic sort of naturopathic approach for introducing a food is like a good amount of it, multiple servings during the day if needed, if you don't see a response. And it could take, typically with GI symptoms or rash, GI a lot of times can pop up like in terms of symptoms within the hour of having the food, but it can be up to 24 and even as far as 48 hours after you've had that introduction day. So then you want to wait for those symptoms to go away. If you don't have any symptoms, I tell patients to wait 4 days before they would introduce that next food. And then definitely like keeping a log, journaling, like what you introduced, when, and potentially like those symptoms. Because if someone's more constipation prone, that might not show up until the next day. And so it might not be immediate when they've had that food, introduce something in the morning, they might be all day like, oh, I'm fine. And then they have like slow motility the next and can't go to the bathroom the next day.
Yeah, exactly. I mean, we've done some clinical trials where we've talked about 3 months elimination that people have been done. So that 3 to 4 months is a really good idea. And then I've heard some providers say, look, start with the 1s and 2s and 3s, and then gradually build up in terms of when you're reintroducing. So in essence, you're giving the 4+ even longer time to stay out. Obviously, in your example of just the 2 foods, that's probably not so good. But in terms of for like that second patient, that probably works really well because you've got so many there on the kind of 1+ and 2+ level, which makes sense. Now, I did some data kind of analysis beforehand. So you've done 108 tests, Jen. So that's a pretty good number, to say the least. So what I wanted to check with you is a couple of things, and it sounds like as you were going through it, you've become a bit more forceful on the when you test people. So that was one of the questions, and then the second one was the types of patients that you're using it on. Is it just the kind of gut related now, or is it kind of broadened out any from there?
Yeah, so definitely anything GI for sure is just like an easy recommendation for patients. Like they get that. Also anything in the skin category, eczema, acne, like skin conditions, again, like an extension of GI is how, you would think about that. And then autoimmune patients really like set off big alarm signs for me in terms of food sensitivity and gut barrier. So those are probably like the biggest reasons I do it, but then also patients who are dealing with sort of like chronic fatigue, brain fog, chronic pain, like those categories too, I would definitely consider fit testing in those patients too.
Okay. And then picking up on your baking soda test, there's a question here from Melvin. What is the time cutoff for the baking soda test?
Yep. So it's the guidelines are we have them do a 1/4 teaspoon of baking soda and 4 ounces of water, and they shouldn't have drank any water like that morning. And then, so you're doing it first thing when you get up, drink it, set a time, like a stopwatch on your phone. And then it would be, if you're burping within 30 seconds, that's probably a true hyperacidity situation, like they are producing too much acid. Normal should be about a minute. Low stomach acid is anything over 2 minutes. And then I tell them, like, if they're not burping by 5 minutes out, like, don't wait for that burp. It's not coming. Although some people will report, oh, I had something, like a little bit of something at 8 minutes. But the farther out they're going, they really are probably not producing much acid. And then if they are a candidate for hydrochloric acid, like to supplement with betaine HCl, then that's sort of the next step to confirm like, okay, this is making a difference. or even, you know, some people aren't comfortable with taking that, or they don't want to take pills, which, you know, they may really need to. You can start them on sort of like bitters, or apple cider vinegar is a nice kind of gastric stimulant that they could do. That's pretty safe.
Okay, cool. And there's a question here from Candy Garrett about how often do you see hyperactivity behavioral management issues linked with food allergies and food sensitivity? I'm just one quick comment on that, Candy. What I've seen in the last 14 years, which I found fascinating, is when we did a clinical study, we saw anxiety, depression about 14 years ago, but maybe didn't have the courage of our convictions. And so I would argue that it's been really a fascinating change where traditionally we'd hear GI docs talk about, you know, issues with behavioral conditions linked to the gut. Now what I'm hearing is neurologists talking about the other way around. So in terms of from brain related to the gut. So it's interesting how we've seen, in terms of the type of practitioners that we've seen using the test, it's moved from kind of gut focused to brain focused, and it's now brain focused back to gut focused. So it's kind of interesting how we've seen that in terms of the types of providers that we see with that gut brain connection. But Jen, more importantly, from your practice perspective, what have you seen?
I would totally agree with that. That's another one I definitely missed in my list, is definitely like hyperactivity, ADHD, kids. Like, this is a great tool to screen if you're working with a, you know, a pediatric population, because even parents will come in questioning food sensitivity on their own. But there's definitely data to suggest food sensitivity related to ADHD. But then, of course, like when we think about depression and anxiety and mood disorders, and even like neurological disorders, that like blood-brain barrier, the gut barrier, that's all connective. And we, you know, your neurotransmitters are certainly manufactured in the gut, the majority of them. So there's this whole link between gut health and mental health. So that's another great category to really consider doing fit testing with that patient population.
Fantastic. Well, and then as hopefully you guys can see on the screen now, we're doing an offer now for the Fit 176, which is normally wholesales at $395 in terms of providers, and so we're discounting that down to $200. So again, if you go onto the KBMO website, kbmodiagnostics.com, and go under new to KBMO, please quote Dr. Stagg, and we'll extend that offer to you, and we'll send that out. So again, that's just an offer. Thanks for everyone for listening. Thanks very much, Dr. Stagg, for such a great presentation. That was fantastic to hear, again, from the trenches, as it were, how the test is working, and how, more importantly, some of the supplementation and how it works in the round. Because as we're very aware of as a company, it's not one thing in isolation, and that's one of the reasons I think we work with providers versus direct to consumer. It's always more complex, it's always more nuanced than one thing, but it's nice to be one of the key tools for a lot of the providers to use. So again, thank you very much indeed. And any final takeaways for everyone?
Yeah, I would say, like I mentioned it during the presentation, is to like, don't leave it for the last thing to consider. A lot of times it's kind of like down the list of things to do, and you should really prioritize it, because I'm really seeing great results with it.
Excellent. Great. Well, thank you all for your time. Much appreciated. And again, hopefully you'll be able to take up that offer that we just highlighted there. But more importantly, thank you, Dr. Stagg. Great chat. And thank you very much indeed for your time. And thanks everyone else for listening as well.